thank you. My other disclosure is that I'm an unrepentant technophile and early adopter, but actually so is my whole department, which I think was one of the attractions. So as W says, I've a long interest in inhalational kinetics, and another thread of my interest is in data collection and data processing. And as part of that, we've been collecting gas flow rates since the early 2000s, actually when we got our first electronic machines that would export the data to us. And we got our first dozen ISIS with end-tidal control in 2011. The graph on the bottom there shows our journey with average fresh gas flows. We're sitting around about 800 mils a minute across the whole case as our typical gas flow. New Zealand's quite a long way away from here, but people from Europe are equally as far. The picture on the right is the Earth centred on Christchurch, my hometown, and you can't see any of the Americas there. And in fact, we're just over the we're just over the right-hand corner, and the whole rim of the Americas is about 12 hours flying away. We have some, if you like, cultural differences, so you need to think about what I say through the lens that I'm not a US practitioner. We're the major hospital. We're not quite a quaternary hospital for the South Island with 34 ORs. We haven't had regulatory limits on fresh gas flows with SIVO since the mid-1990s, pretty much in line with the EU. And the ISIS was released with end-tidal control, which fitted into the things we were interested in, just as we were looking for replacements for our ADUs. Now, kinetics of drugs is important. This is the most, sorry, apology to the GE folks, this is the most important slide I'm going to show you today. It's the kinetics of caffeine, and what this shows is that the time to peak effect is about the same, about an hour, regardless of how you take it. Now, what's interesting about this is that there's a lot of kinetic stuff that goes over most people's head, but if you explain this in terms of coffee dosing or perhaps alcohol dosing, people suddenly understand why giving that extra bolus of propofol might not be a good idea. Okay, in the same way as coffee, from preparation to having its effect, is a cascade, and we learn about the oxygen cascade. We can apply the same thing to volatile anesthetics. And the important thing to remember is a lot happens at every step, from what you dial up on the, the wonderful and beautifully designed analog technology on the right there, through the inspired concentration, what you breathe out, the arterial concentration. And then there's another step between the end-tidal and the effect, which is what we're starting to measure. Again, just the volatile cascade. This is an example from a simulation program we run. I want you to focus on the blue line there, which is approximately the brain or the effect site concentration. And what you can see is how much the end-tidal concentration in green, the expired concentration, the inspired and the dial in yellow have to change to maintain that concentration. And again, that there's a delay between end-tidal and effect. And just point out that the rate of rise of end-tidal concentrations isn't what we read in the textbook, because the inspired concentration isn't actually constant like the textbooks. So, what does end-tidal concentration do? I'm going to talk about this very much as a user and let Carl talk about the technical aspects. You simply set the target vapor concentration you want, set the target oxygen you want, and set the minimum gas flow that you want the machine to deliver, and the machine just does the rest. So here, 31% oxygen, 300 mils a minute fresh gas flow, a target of 1.4%, and that's it really. Here's just an example of of what happens very early on in the case. We've had the first breath of SIVO given here. 1 minute later, the flows have gone from 3 litres a minute down to 1 litre a minute. You can see there's still quite a lot of sevoflurane, although mils per hour of liquid sevoflurane is a fairly meaningless concept for most of us, but it's a way of quantifying what's going on. And here we are 3 minutes into the case. The flows are now under 500 mils a minute, and we've achieved the target. And there hasn't been any user interaction with with any of this. So to summarise yet again, automates vapour and oxygen delivery, achieves and maintains the concentration. It's more precise, moves the control point closer to the site of action, allows a reduced fresh gas flow, I'll come back to that in a minute, definitely reduces workload, and less attention needed for step changes, and the ninja question about how we behave when we when we want the vapour concentration to drop. So inhaled agents are different from IV agents. 100% of the IV dose gets to the patient, and our aim is to align the delivery to patient needs. With volatile anaesthetics, there's an enormous amount of waste, if you like, that the amount the patient actually needs compared to the amount delivered from the vaporizer is massively different. We got into monitoring the fresh gas flows from a cost perspective, but the environmental thing has already been there. Now the paradigm has shifted a bit. There's still concern about room effects and some of the other effects of heat and moisture conservation, but really it's down to avoiding the waste of the vapour. And I would argue that it's a more elegant way to do things, to align the dose you use to the amount you need. People give lots of reasons for using low fresh gas flows. They essentially come down to the fact that it's complicated and dangerous. Here's what I was using in the mid-90s. The real risk there is all those possible places for disconnection. My take on these objections is that people object to the extra effort. The disconnect between fresh gas and inflow concentration, people struggle with, and I would argue that end-tidal technology gets around all of that. Personally, I regard compound A as a non-event. It's also said to be complicated, and I think some of the low flow and closed circuit zealots have done their cause damage with their complicated equations and one thing and another. But I would argue most of these attitudes are a hangover from days of minimal gas monitoring. So here's a brief, and again, I'm sure these guys will have much more elegant photos of slides of what's going on. The green is the set target. The sort of brick-coloured colour is the actual end-tidal. The blue is the fresh gas flow, and the yellowy colour is what the dial's doing. You can see you get a little pulse of fresh gas and vapour into the circuit. My perception is the machine then sits there for a while and sees what happened and then gradually ramps it up to achieve the target within 2 or 3 minutes. And what's interesting is that's independent of what minimum fresh gas flow you set. So even if you think the machine needs help by setting a higher fresh gas flow, it actually doesn't make any difference to how quickly you get there. This is where I find end-tidal control and the data from it gets interesting. So here in the middle of a case, we're maintaining a constant target. The end-tidal and the target stay roughly constant, but look at what happens to the inspired concentration. It's actually dropping about 10% an hour. So even with high flows, you would need to keep on adjusting, and nothing else happening, you would need to keep on adjusting the vaporizer down to not get an overshoot. I love this example. This is what happens when you swap the absorbent canister. On the left, fresh gas control, 1 litre a minute. You can see where the canister's changed, and you can see that after a couple of minutes, we're back to about half where we were, so you could get over that by doing something, but it takes a while. On the right, with end-tidal control, the machine does a bit of a hiccup as you change it, and then within about 10 breaths, without you doing anything else, you're back to the end-tidal target that you'd set. I want to talk briefly about fresh gas flows and this conceptual model, if you like, we developed a few years ago. A lot of people talk about the important thing being the minimum flow they use in the middle of a case, and that's in the middle maintenance phase, and there's nothing else going on, and the Sudoku's done and all of that sort of thing, and you can tweak the flows down. But actually a high fresh gas flow at the start of the case has an overwhelming influence, and this applies even if you're using moderately high fresh gas flows for your maintenance. So conceptually, this is about what can the user control. We can control how high a fresh gas flow we use at the start of the case. We can control how long we do that for. We can control the rate of the maintenance fresh gas flow. We obviously can't control how long the case is, as much as we would all like to. And again, just to repeat that early fresh gas flow matters. This is a little example of a 90-minute case, 8 litres a minute for 10 minutes and 2 litres a minute, or 6 litres a minute for 5 minutes and then 2 litres a minute. Actually makes 20% difference to your overall vapor consumption. And I guess my message for those of you using end-tidal control or who will soon be using it is just turn it on as soon as you can. Automated delivery of vapor isn't new. Here's a bunch of papers from the mid-80s. None of these obviously ever reached clinical use. Some more recent data, though, related specifically to end-tidal control. This is from Philip Barclay in Liverpool, in the UK. They basically showed that vapor use was down 50% with end-tidal control. Interestingly, they only use, all of these studies actually, I don't think, show the full benefit because of the constraints of the study, of a good study design. Stanley Tay from Melbourne, they looked at the transition and looked at the number of bottles of sevoflurane being used. Their consumption was down 25%. And again, they were using reasonable flows, and I would argue their study design actually decreased the benefit they were able to show, but it's pretty convincing. This is an interesting one from Groningen, from Wetz et al., because this is a group who are experts. In fact, they chose for the study people who are experts at using low flow anesthesia. So they were using 500 mils for the case. So they actually used slightly more with end-tidal control, but they achieved the target faster, much less changes, and the concentrations were much more stable. And this is my favourite from Italy. Similar Sevo use. They had to achieve the target they were given. They had to make 100 adjustments in the manual group and no adjustments in the end-tidal control group. And again, a good solid quote. We demonstrated that end-tidal control is as good as manual control, but provided more time for the patient to take care of the patient and could result in easier and safer management of low flow anesthesia. And I think that sums it all up quite nicely. My sort of take-home measure, it just works. And these are a bunch of other studies, both with end-tidal control and other technologies that are available in Europe, and they all say the same. They all say the same thing. And then we become supervisors and overseeing rather than being tied up in the minutiae of the purity of our adjustments. There are a lot of people who don't like the idea of end-tidal control. They don't like the idea of any automation. They don't like the idea of taking the craft and the art of anesthesia away and turning it into a precise science. And I've come to think this is an example of gravity wells. And I've come to realize that actually for most of us, change is hard, and changing your practice, you might get some failures with a new technique, or your cases might not wake up as fast, and we've all got this production pressure and all of these. There's a whole lot of things which make it nice and comfortable to keep on doing the same thing we've done. So here's a bunch of reasons people give for why they shouldn't change. Try and do this at home. I can't remember where this example came from, but here we're sort of stressing the controller a bit, and I'm sorry the colours on these slides, which come from different places, are all over the place. But you can see that as the concentration goes down, the green is the fresh gas flow. There's a few little bursts up in fresh gas flow to wash out or wash in the vapour. The inspired is going all over the place, but the end-tidal is pretty closely following the path that we're setting. So we can do at least, we can probably do as good a job as a machine. We can debate the rest. The proper anaesthetic is an interesting one, because what is a proper anaesthetic? And I would argue that most of the way people learn anaesthesia, clinical anaesthesia in the operating room, doesn't teach them anything about kinetics. It tells them how to administer a recipe. And in fact, watching what the controller is doing can tell you a lot. And do I teach a trainee the same way I was taught 30 years ago with a completely different tool set? I've always done it this way. No time for that. What happens when it breaks? The modern kit's much more reliable. It doesn't really break, but yes, you need to understand how a device fails. Cost. Admittedly, sevoflurane prices have come down a lot in the last 10 years, but our payback time for the end-tidal control software was under 2 years. This is one of my favorite examples, and I'm almost done. This is, so here we've got, now the green line is carbon dioxide, and this is an off-pump cabbage. So the surgeon picks the heart up about here, and what happens is the CO2, which is a pretty good marker of cardiac output, plummets. But look what happens to the end-tidal agent. There's a little bit of a blip, and the controller very quickly turns the inspired concentration down and actually manages to maintain a pretty good constant target. And again, what would you have to do to deal with that if you were doing it manually? A question that sometimes comes up is, since the system's controlling both, doesn't changing the oxygen upset the vapor and suddenly use a whole lot of extra vapor? Here's just an example we found. Turning the oxygen down from maximum to 50%. This must be quite old because I don't use that much anymore. There's a little blip in the fresh gas, but really it doesn't produce a significant overall change in your average fresh gas flow. So where are we after 12 years? We had in all 34 of our OR by 2015. Still not out of theatre, but I need these guys to fix that. It's used about 96% of the time across all the cases. If you look at when you look at a major incident, major trauma, and go back and look at the flow rates people are using, they're using low flow rates, which means that people, even in a sort of crisis situation, are just turning on the end-tidal control and letting the machine look after all of that stuff. And we've got some evidence that in pediatric practice, again, if patients are about a third of our kiddies are induced in an outside room brought in, that people are just turning the end-tidal controller on. So here's the advantages, which I've pretty much stated before. The graph on the right is an interesting one. It shows both our fresh gas flow and our rate of use of end-tidal control, and you can see the crossover. We had a little bit of a learning curve. It took a little bit of time, about 18 months for people to get comfortable with it, and that had a dramatic effect on our overall vapor consumption, but it was worth the wait.